Good afternoon, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. Today, we are delighted to welcome our very own Dr. Joelle Donofrio-Ödmann to present her talk entitled Little Lungs, Regional Rumbles, a crash course in pediatric ventilation and hospital musical chairs. What an intriguing title, and we know she's an engaging and powerful speaker. I cannot wait to hear her talk. Dr. Donofrio-Ödmann is a triple boarded physician in pediatrics, emergency medicine, and EMS. She's Associate Professor of Clinical Pediatrics and Emergency Medicine at UC San Diego and also serves as Chair of our EMS for Children Advisory Committee, EMS Medical Director for Rady Children's Hospital, and Deputy Chief Medical Officer for San Diego Fire Rescue. With over a decade of experience advancing critical care for critically ill and injured children, focusing especially on pediatric airway management, resuscitation, and out-of-hospital cardiac arrest, we are delighted to welcome Dr. Donofrio-Ödmann to our EBM lecture series today. Over to you, Joelle.
Hi, it's really good to be here. Thanks for the invitation. First off, I have to apologize. I got pretty darn sick. I don't know who to blame, my patients or my children. But so if I occasionally have to mute myself for a cough, I apologize ahead of time. So welcome to my talk. This is not gonna lie. I love this talk. This was really fun to put together. And I think it shares something I'm really passionate about. So let's get into it. Um, I really, hold on one second to minimize. Well, I really have no financial conflicts of interest, but honestly, I do want to improve the care of kids. And when you take better care pre-hospital, it makes my job easier in the ER. So maybe I have some conflicts of interest. Our objectives today are really to cover the why, who, and hows of pediatric respiratory distress. And we're really going to get into the basics. Let's start off with anatomy and physiology, and let me show you how children are designed for respiratory failure. Can you guys hear that? So, first off, kids are prone to an upper airway distress for a myriad of reasons. Do you see what I mean? It starts
Well,
off with their,
sorry to
yeah.
interrupt. At least I did not hear it. You may need to unshare and
Okay,
turn on
that's
your
okay.
sound
It's
and
it was
reshare.
just it was a little bit of stridor with respirations. So kids are developed for respiratory distress. Do you see what I mean? It starts out with their giant lollipop heads. Check out those kinked airways from that large occiput. The kinked pediatric airway is due, as we know this, right? Everyone's told you this over and over and over. Kids have large, prominent occipits. This means that we need to consider positioning in order to get that proper sniffing position. And it's going to differ based on the age and size of a kid, with the goal to really get the sniffing position, aligning the external auditory meatus to the sternal notch, whether they're laying down or they're sitting up. And you might even need a little bit of bumps to help you out. Just remember for the neonates and the small infants to really watch your fingers and make sure that they stay along the jaw bone and don't actually press in the soft tissue and collapse the airway. So I love this image. Check out how the infant has no oropharynx. The uvula is practically touching the epiglottis. Now, this allows for a better closure of the oral intake from the air intake, which helps with the feeding. But it also means, as we know, if you're an infant less than 6 months old, you're an obligate air breather or an obligate nose breather. And this is a really big deal if you get a respiratory infection that occludes your nose, like such as RSV, where it causes sloughing of the entire nasal lining. And in addition to only breathing through their noses, they have relative larger tongues. And this is a weird fact you may have never known. The area that has the highest airway resistance is actually the tip of the nose. So this is why having OG tubes is so much easier than NG tubes, and why giving mask by oxygen is sometimes easier than nasal prongs. So just a quick tip to remember for the nose, the NGA, you're going to pick the NGA, the NPA, that is the size of their pinky, because everyone's pinky can fit in their own nose. And for the depth, you're going to go nose to ear, and the OPA is going to be your mouth to your angle of the jaw. So the no oropharyngeal airway in the less than 6-month-olds, a relatively large tongue, the smaller nasal apertures, these are key to remembering overall, but they magnify when you're dealing with kids who may have craniofacial disorders, such as Treacher-Collins syndrome, where you just have an underdeveloped cheekbone and jaw, but you're completely neurointact and normal. Children with Beckwith-Wiedemann syndrome that have a persistently growing tongue as they get older, among other things, or Down syndrome, which has a relatively large tongue and a small midface and hypoplastic lung, or hypoplastic nose. So as we're moving down the airway, I thought I'd share you guys my favorite. I'm gonna pause because I think you need to know this is my all-time favorite video. And I can't see anything besides my own screen, so I need someone to unmute and be all excited with me before I show you the video.
I'm excited.
I need more than Jenny. Come on, guys, be excited about this.
Yay!
Woohoo,
There
let's
we
see it.
go. There we go. Let's do it. Let's do it. This is crazy. So they have a kid and they have a VL looking at that lovely floppy omega epiglottis, and watch what a jaw thrust does. And jaw thrust, ladies and gentlemen, check that out and release the jaw thrust. Oh, pop it back up. Release. Pop it back up. A jaw thrust is a very life-saving maneuver. And even when you have a pediatric infant omega-shaped epiglottis, it's still powerful in opening up that airway. So we're still in the upper airway, but we're starting to move lower into the larynx. And moving down, you can see that the larynx sits higher and more anteriorly, and this makes intubation more difficult the younger the age. And as we know, and I've talked about it before, the epiglottis is smaller, more like floppy, and really that omega shaped. And this can make airway a little bit more difficult to access and more prone to extubation issues if any trauma and swelling. So continuing our path down the track, we find that the airway is even more complicated by the fact that, as opposed to adults, where the most narrow portion of the airway is the vocal cords, in kids, you have a triangular shaped subglottic portion, with the subglottic narrowing, which means that, your tube might pass the cords, but not the subglottic area. And minimal trauma in this area can actually cause tracheal obstruction because the larynx of the trachea are so small. So getting lower into the trachea, we can see that, and are you guys able to see my mouse as it moves around?
Yes.
Yeah.
Yes.
Perfect. Awesome. So as you get lower, you can see, look at this cute little infant 4-millimeter trachea compared to this large adult trachea. The same cold in both the adult and child lead to a 2-millimeter change. But while the adult might just have a little bit of a cold, change in voice, a slight increase in resistance, the infant trachea has a whopping 16-fold increase in resistance. And that's because resistance is equal to this complicated formula, which is basically resistance to the fourth, or radius to the fourth power. Any tiny change drastically increases or decreases the resistance. They have a short, narrow trachea with significantly increased resistance. And this is why croup is a younger child issue. And we aren't rushing to give nebulized. You can't hear this, but you have a kid that's got a barking, coughing, going. And this is why you don't see this with adults. We're not rushing to give nebulized epinephrine and Decadron to adults with a parainfluenza, but we are with kids. And a little side note, throughout the US right now, we are seeing more severe croup than we have in years past. And we're seeing it in older kids, and we're having subjectively more ICU stays. And even on the East Coast, they've actually had 2 arrests from croup. So really pay attention to your respiratory distress and your upper airway right now this winter season, because it's a little bit more problematic than we've seen in the past. So moving lower, because we're doing an anatomy and physiology lecture. Moving to the rib cage section, you'll notice that the carina sits higher and it has a steeper slope to the right main stem. And this means that your trachea is not only more narrow, but it's shorter, which increases the odds of both extubation and right main stem intubation with movement. So remember also, look at this picture. Do you see the kid's neck? No, you can't see the kid's neck because kids have no neck. If you actually want to see if there's signs of tracheal tugging, you actually have to elevate the kid's head, have them look up to see if they're working so hard that you have tracheal tugging. Kids have no necks. So we're going to move a little bit lower. And you'll notice, do you see he's got the tracheal tugging right here? You can see he's pulling here. He's tachypnic. The bronchioles have the same problem with the narrowed airways leading to increased resistance as trachea did, but they also have more mucus plugging. Now, peripheral airway resistance is higher in kids, and disease in the bronchioles can be serious because peripheral airways make up a significant portion of the total respiratory resistance in kids. Do you see how you expose and you can really see that he's working to breathe? He's really tachypnic. So this gets added because kids less than 2, not only do they have that mucus plugging and the increased work of effort when they get sick with the bronchiolitis, they also can't cough. If you're under 2, you have an ineffective cough. And so infections such as bronchiolitis lead to respiratory distress. And if you have a congenital disorder such as Cartaginer syndrome, where your cilia just don't work, or cystic fibrosis, it gets even worse. And yes, I did throw in this slide because I like this GIF. I thought that was actually a really cool one. But basically, with pediatrics, anything that can go wrong developmentally can go wrong. All possibilities are out there. So now we're getting down the track to the alveoli. Starting at 36 weeks gestation, the body has mature alveoli. But this is the weird part. Did you know that they continue to grow and develop throughout the young child period? That's right. You get alveolar development all the way through your young childhood period. So your infant lung has more airway tissue and less parenchymal tissue. So your alveoli and interstitium just don't exist as much than adults. And they also have really tiny, cute, adorable, small lung volumes as well. So because they can't increase their total lung volumes, they have to increase their respiratory rates to compromise. Just in case you're listening to me, wait a second. 36 weeks is when you have mature alveoli. We have kids born before the alveolar stage all the time. So remember, alveoli develop the 36 weeks through the 2 to 6 years of age, but we're having preemies born in the canicular stage. Like, look at this. They don't even have that much like alveoli. These lungs aren't even supposed to be filled with air or exposed to oxygen besides mom's venous blood yet. And this can lead to bronchopulmonary dysplasia, or what used to be called chronic lung disease. And why do you care? Why am I telling you this? Because we basically treat them like asthmatics. So if you see a kid who's working hard to breathe and they were a preemie, that means that they were born without proper alveolar development, and we're going to treat them very similarly to asthmatics with breathing treatments, steroids, MAG, etc. And because we're talking about newborns, I just can't help it. Regardless of prematurity, when you have a newly delivered infant, remember that in utero, the placenta delivers mother's venous deoxygenated blood through the umbilical vein to the ductus venous or ductus venosus, into the IVC, to the right heart, to the pulmonary trunk, to the ductus arteriosus, to the aorta, umbilical arteries, and back to the placenta. And then you're delivered, and bam! Welcome to the air world, little liquid-based creature. They have to suddenly activate a breathing reflex, open up their lung with this super oxygenated room air, drop their pulmonary vascular resistance, and increase their systemic resistance. The right ventricle has been doing all the work in utero, and now the left ventricle has to get the work. And their lungs have never been opened. This is a huge shift, and that's why we see a lot of respiratory distress in that newborn period. So now backing it to the whole pulmonary architecture surrounding that is the rib cage. Now, the infant's chest wall is mechanically efficient, or is less mechanically efficient, and it limits lung expansion, which leads babies to belly breathe. And so anything that interferes with the descent of the diaphragm, such as, an overly inflated stomach or intestines, hopefully that doesn't mess up your presentation, or can seriously impair your breathing. So their chest walls are more compliant. They have an elastic recoil that's close to 0. And at birth, the chest wall is 3 times more compliant than the lungs, and it takes a whole year to approximate the adult values because of just how cartilaginous the ribs are. Now, because of the chest wall structure and the belly breathing, this limits their ability to increase their tidal volume, which, as I said before, means that they have to rely on their respiratory rate to compensate anytime they have respiratory distress. So, the harder a child tries to breathe, the less efficient and more labored the breathing becomes. So you start to see some intercostal retractions, some subcostal retractions, some supraclavicular, tracheal tugging, sternal retractions. And when you're moving so hard, you start having a head bob. That's a really bad findings. So really look at the level of distress that they're doing. Now, this is a study, and they had in the OR, basically, they had hyperoxygenated patients and they had apnea because they were given a paralytic. And then they went, how fast do you desat? They did not let them drop to 0, but they just kind of watched what their desat levels were. And you can see like a healthy, normal 70-kilo adult can go out pretty far, like 8 minutes before they desat. A moderately ill adult is around like 5 minutes. However, a 10-kilo kid drops really, really quick. This isn't even a sick kid. This is a healthy kid. So when you think about the pediatric considerations that they have small tidal volumes, they have incomplete alveolar development, they rely on that respiratory rate. This explains why they desaturate so sharply and rapidly with apnea, especially when you consider a neonate consumes 6 to 10 mLs per kg per minute of oxygen compared to the adult's 3 ml per kg per minute. They consume more, like twice as much oxygen. This is why when you look at their respiratory rate, they have a respiratory rate of 30 to 50 compared to the adults 12 to 14. Isn't that crazy? And we're just talking about like anatomy and physiology, but think about the brain. In addition to having little oxygen reserves, they're not great, like they're not well practiced at breathing. This example, so if you watch this is an immature breathing pattern in preemie infants that leads to central hypoventilation. So you get apnea. They're like, oh, I forgot how to breathe. And then the apnea leads to a bradycardia, which leads to a DSAT. They call them ABDs. And this is just because their brains are not fully myelinated yet, and they literally just have issues with breathing. And it can take time to mature. Even term babies can have periodic breathing of the newborn while they're working on myelinating their little brains. So I hope this little anatomy and physiology section really proved to you that neonates, infants, and toddlers are designed for respiratory failure, both upper and lower. And it also highlights why all of our fellowships in pediatrics are so long. The PICU, neonatology, pediatric emergency medicine are all roughly 3 years. And I love this. This is a video one of my paramedic students sent me of his son. He said I could use it. So based off of anatomy and physiology, let's put this all in context. We can predict, based off of what I just taught you guys, that young kids are going to have more respiratory problems and that their respiratory distress can really be categorized into upper versus lower processes. So let's look at the extent of this. As we saw, the smaller children are designed for respiratory distress. And as you can see, the bronchiolitis is the #1 cause for hospitalizations in pediatrics, leading by over 10K over the second diagnosis of pneumonia. A majority are admitted at urban teaching hospitals, followed by freestanding children's hospitals. And this really spells out high interfacility transport rates to me. Now, I bet you were thinking this whole time I was talking, like, why is she focusing so much on infants and infants and neonates? And this is why. They account for a majority of the hospital stays in pediatrics. And for the younger patients, when you look at the ICU patients, the younger kids really account for more of them. And I'm sure if you took this 1 to 4-year-old group and you broke it down, it'd be primarily that younger toddler age range. And the admitting diagnoses, when you look at who's getting admitted to the ICUs, they're respiratory, and they're just going up with time. And just in case you're like, well, what's the next category? The next highest category is ingestion poisoning, and that was only 15% compared to 35% respiratory. And when you look overall at the PICU admissions, they're increasingly kids with complex medical histories and technology-dependent states. And when you look, there's increasing admissions to very regionalized and often very far children's hospitals. And this is across the nation. So again, makes me go intra-facility transport. So we need to be looking at that. So are your EMS agencies ready? You are going to get 911 calls for infants and toddlers in respiratory distress. I mean, especially now, we're going right into the season. So do you have your equipment ready, your protocols, your education, your meds? And do we actually have any ways to see if we're doing the right thing through QA? For the first time ever in 2025, we did a national survey to see how ready our EMS agencies are to take care of kids, but we're still interpreting the results and figuring it out. But this is going to talk a lot more about our state of pediatric EMS preparedness, education, equipment, protocols, QA, QI. But in the meantime, we have published evidence-based guidelines to look at EMS treatments for croup, bronchiolitis, and asthma. But how should we be doing education, protocol development, and QI for respiratory distress and failure? And where should we having these patients transported? Because it's not just the protocols, but it's really looking at the system of care. You can see that when you look at the hospitalization rates, a lot of them are for bronchiolitis in smaller kids, and a lot of them are to the children's hospitals. Now, we talk about this, right? The newest term on the systems of care block is pediatric systems of care. So not just stroke, STEMI, cardiac arrest. How do we get the correct pediatric patient to the correct place to reduce secondary transfers, reduce length of stay, and overall improve patient outcomes? A majority, this is looking at all US hospitals, a majority of US hospitals do not see pediatric patients frequently. And obviously, not many of the rural and remote hospitals see pediatrics frequently either. And when you look at overall all hospitals throughout the US, only roughly 30% even have a pediatric ward in them. And if this is a very ill child and it's a higher level of care, there's only 80 tertiary children's hospitals and an additional 136 kids hospitals within a general hospital. Basically, 6% of hospitals across the US are able to actually take an ICU patient. So just think about that for a second. What's our San Diego County pediatric system of care? Where do you take them? Where do they end up? Are we getting the right patient to the right place at the right time? And are all of your hospitals ready for kids? Remember, infants and toddlers are portable. You can carry them anywhere. Parents do. They come running into the trauma bay with their sick baby. And if we know that this is a common pediatric complaint and it's the top admission etiology, are our hospitals prepared with equipment, treatment guidelines, and transfer indications for bronchiolitis, asthma, and croup? Now, we have the National Pediatric Readiness Project. It's coming around again in March, so we should be looking at this and going, hey, are all of the hospitals in San Diego ready? Where are our gaps? What are our scores? Are we ready for the next survey? And we should really consider using our tertiary children's hospital and sharing the treatment pathways for the major diagnoses, especially for croup, bronchiolitis, and asthma. And these are pictures of our Rady Children's algorithms. So let's talk about helping the respiratory distress. Now, because we know we're going to see this, right? But how do we actually help them? And given my limited time, I'm not going to dive into the medications. I'm really going to focus on the non-invasive positive pressure. So just as CPAP has been really transformative in the adult world of EMS, right? Decrease intubations and heart failure and COPD, non-invasive positive pressure ventilation has been transformative in pediatrics. The key differences in kids is how the devices actually fit their faces and the capability of the machines to deliver the air needed. We typically start with a humidified and heated high flow nasal cannula, increase to CPAP, and then to BiPAP or non-invasive positive pressure ventilation. And in the neonates, we can even do nasal high frequency oscillating ventilation or nasal NAVA, which is nasal neurally adjusted ventilatory assist using the diaphragm. That's right. We can have basically intubation level mechanical ventilation through the nose in our neonates. The same physiology applies in pediatrics as adults when it comes to pressure and time curves with CPAP and BiPAP. Here are some of the close-ups of the devices used. This is the RamCam. So the RamCam was actually developed when I was an intern at LAC USC, and one of my neonatology professors actually invented this. His name was Dr. Ram. We said it was named after him, and he said, no, it's not. It was named after the horns of a sheep because they're curved. And when you look at it, they're larger diameter and they're longer. And what happened during my 3-year pediatric residency is we went to intubating neonates all the time in the NICU to very rarely intubating. It was really transformative. And this is what we're seeing with high flow nasal cannulas, the CPAPs, the BiPAPs. Like, we're seeing a lot of success with our non-invasive. We typically max out at 2 liters per kilogram max. Most hospitals vary on what they do allow on the pediatric ward versus the pediatric ICU. So a lot of times this changes where we admit a patient to. If the high flow is not enough, then we move them on to CPAP. And we don't just look at oxygenation, because many of the patients that we have on non-invasive positive pressure, their oxygen's fine. It's based on the work of breathing. How severe are their retractions? And just to show you how much we use this and we allow the patient to really fail before we move forward. This is an example of how they're using non-invasive positive pressure ventilation. This is for a less than 32-week preemie neonate. This is the guidelines from Hopkins. So as you can see, they have age-appropriate respiratory rates, and they trend to really allowing permissive hypercapnia. And they have the lowest oxygen setting possible to minimize the harm from reactive oxygenation species. But look at this. In order to fail the nasal ventilation, you have to have severe apnea requiring not one episode of BVM, recurrent bagging. You have to have 2 consecutive blood gases that are really crappy. And you have to have higher FiO2 for more than 2 hours. So we really try to do non-invasive ventilation as much as possible in pediatrics, and we have really good devices for it. We have BiPAPs, we have initial settings, and we usually use our own starting pressures unless they have a home BiPAP, in which case we start with their own home BiPAP numbers and the increase is needed. One of the differences between kids and adults is that usually we have to have sedation. Usually kids don't like BiPAP as much, and so we usually use the dexmedetomidate for our preferred agent at children's. Key for EMS is that if you're bringing like a patient who has home BiPAP in, even if they only use it at night, bring their equipment. It's so helpful. It's really hard when you have a patient who's getting admitted and they're on home BiPAP, but their BiPAP's at home. Trying to get all this stuff set up for them in the hospital is a little bit trickier. So always remember, bring any equipment the patient has in with them if it's possible. So in case you're like, and for years I have been going, we need pre-hospital pediatric CPAP. We need it. We do it for adults. When can we do it for kids? Air has had bubble CPAP. Why can't we do it? And I was at a meeting, I think it was like last year, maybe NAEMSP. And I was sitting next to my friend Chelsea Kaddish, who's a pediatric EMS doctor in the Midwest. I was venting about it. And she went, oh, we have pediatric CPAP. And I'm like, not air, not like peds transport. I want it on ground. And she went, no, we have it on ground and it works wonderfully. And the kids tolerate it great. Nationwide Children's got together with Columbus Fire and they use a full mask pediatric CPAP. They have ones that they're small and they're animal shaped. And she said it's working really well. So I was excited because something I've been wanting from like a decade is finally here. But the thing is, if you're going to use it in your agency, in your ERs, you have to remember to have relatively objective criteria that your staff are familiar with. So this is our Rady Children's, it's like our reactive airway severity scoring. And we look at, what is their oxygen? What is their respiratory rate? What is their general appearance, breath sounds? And if you notice, you're like, yay, 1, 2, 3 points. But when we get to the work of breathing, this is really where we give a lot of the points to, which means that your providers need to be able to identify and quantify retractions. So teaching them, how do you actually recognize the mild versus the severe? And you can see this little guy. He's happy. He's a happy bronchiolitic. But when you look at his level of retractions, you're like, man, you're working. He's got some subclausals. He is a kid that we would work on suctioning first, and we'd clear all the snot out from him. And when he looks up, you can see he's having some tracheal tugging as well. But he ended up not improving with the nasal suctioning. We even tried 1 dose of albuterol just to give it around. It didn't work, so he ended up on high flow. When he went to sleep, he also got worse. We have the same thing for asthma, like having really objective criteria that you can use to assess where are you at, what treatments do you need, and then once you've done the treatment, where are you at, so you can figure out where to scale everything. And again, notice to look at the neck, look at the overall gestalt of how the work of breathing is doing. The degree, you can see that he's very tachypnic, retracting quite a bit. So, croup, bronchiolitis, and asthma, EMS and ED care, knowing protocols, meds, non-invasive positive pressure access, and how to use them. Those are all the things we've kind of been talking about. But I was talking about earlier, can we appropriately QA this? So looking at the 2019 NEMSIS data and the info I've provided about pediatric anatomy, physiology, and indications for hospitalization, when you look at the number of airway interventions, I really think the CPAP BiPAP number is just far too low. Like, I don't think we're actually appropriately intervening on respiratory distress at a high enough level in a way that works in the pediatric population. We're currently working on a publication with ESO looking at how EMS is treating kids under the age of 3. Don't take a screenshot of this because we haven't published this yet. It has been presented at NAMSP, but has not actually been manuscript posted yet. But we're looking at kids less than 3 with upper versus lower respiratory distress. And we were determining this because we had their hospital discharge diagnosis. Was it croup? Was it bronchiolitis? Was it asthma? And then we looked at EMS assessments and treatments. We found for the lower airway, there's 35% of our lower airway patients were admitted, and 5% of those got transferred. But the problem was, if we had only used EMS data and we didn't have the hospital discharge diagnosis, we couldn't have done this because all children were just considered acute respiratory distress and other. We actually, so if you can see, this was upper. So these are your croup patients, and this is your bronchiolitic asthma. And they both basically say acute respiratory distress. This one has croup, but there's not others. So is this a primary impression option issue? Is it an education issue? And if it's educational, is it that they need the education distinguishing upper versus lower? Or is it just which primary impression they'd like them to choose? I mean, it's confusing, right? Especially if you want to know whether the correct treatments were given. So when we looked at our upper airway, it was most commonly oxygen and albuterol. You get some like neb epi third place, but they're exactly the same for your upper versus the lower. So is it that they chose the correct protocol option and then the protocol is not correct? Or is it like, what actually is it? Something's off. So children are designed for respiratory failure, and treatment options vary based on upper versus lower respiratory distress, right? Nebulized epinephrine for stride at rest for croup. You can try your duoneb for your bronchospasm and your bronchiolitis and asthma. And our top EMS calls in infants and toddlers, when you look at the numbers, whether it's in California or across the nation, is for respiratory distress. The top admissions to the hospital for children is for respiratory distress. So should we actually spend some time looking at how we better describe these populations and then how do we better care for them? Could we reduce secondary transfers? Could involvement of non-invasive positive pressure ventilation, such as the CPAP and EMS, decrease length of stay? I don't know. So in conclusion, a whole summary of this, and I think I probably spoke too quick and we went through real quick. Kids, so the why, right? Big heads, big tongues, smaller airways, bigger tongue, less alveoli, flexible rib cages, flat diaphragm. This is why. The who is the infants and toddlers. They account for the majority of hospitalizations and ICU stays. This impacts regional systems from 911 calls through the ERs, through the admissions. Now, how? I bet you thought when I first started this talk, I was going to talk about like actual mechanical ventilation, right? But it turns out the best way to help the majority of patients with respiratory distress in the pediatric population is actually to look at our systems of care, from EMS equipment and protocols to destination hospitals, ED management pathways, and importantly, the ability to improve our QA system. So tubes are sexy, but really changing the system of care for the major cause of hospitalizations is even sexier. But while I'm talking about endotracheal tube, just a little quick FYI on PD part. So PD part is a randomized control trial through PCARN where they're doing supraglottic versus BVM as stage 1, and then they'll take the winner of that to endotracheal intubation. They have enrolled over 900 patients between supraglottic and BVM, and they haven't found a difference yet. So they don't have a clear winner, and they have to have a clear winner before they can compare to endotracheal intubation. So they are still enrolling, and I will keep you up to date with that. So thank you. I hope this was exciting for you. I love this. I think even when making this talk, I found out some new facts about pediatric respiratory distress and why they're so designed for failure. And if you like this style of presentation and you want to learn more about it, my friend Joe Finney, who's also triple boarded, and I have a podcast where we have a bunch of experts come on board. It's free, it's open, and help yourself. So thank you so much.
Thank you so much for an amazing lecture on a super important topic. I cannot help but think back to when we were discussing should we intubate children in the pre-hospital setting and how your work influenced the entire state, along with some other leaders, obviously, and how that change took place. And now we're hearing about this non-invasive ventilation and other types of interventions. It's incredible. I have a few questions for you, but let me first open it up to the group. Please come off mute and ask your question. Put your question in the chat, raise your hand, whatever is convenient for you. And we're getting a lot of kudos, of course, for your, as always, great lecture. Anybody have any questions or comments? Well, let me start while we're waiting. I absolutely loved your picture with what the jaw thrust does in terms of putting the airway into view. That was really dramatic. And I'm thinking back to when we used to do cricoid pressure, and then that turned into burp, backward, upward, rightward pressure, and wanted to see if you had any comments on the use of that technique, not so much for what we initially used it for, but for repositioning the airway, because I know in adults it can be very helpful to push the cords into place in a difficult airway. What do you think in the pediatric airway? What's the latest literature on that?
Are you talking about in the ER during intubation, or are you talking about to help just alignment of the sniffing position for any child in respiratory distress?
Good question. Definitely in the ER for intubation, although it sounds like intubation is becoming very uncommon even in the ER,
Yeah.
but also in terms of being able to ventilate, anything
Yeah,
perhaps help ventilate in the
we
pre-hospital setting.
we we never do any manipulation of the neck to help with ventilation in a BVM status, or really even with a supraglottic airway. It's
Mhm.
really about alignment, like getting that external auditory notch or external auditory meatus, like the ear hole to line up with your external notch, and figuring out what that is needed for the kid. Um, And so chest bumps, head bumps, kind of like really figuring out that angle, helping calm them down. It with intubation, our video laryngoscopes have really decreased the need for it, but we have used that in account like occasions where we do the burp technique with like, and we're doing a little bit more where you put your hand over someone else's hand to help guide it into the right position, and then you say stay
Mhm.
there, and then take it off for your intubation. But we actually don't need to use it very often. It's really getting that positioning, and then our VLs have helped a lot. The other thing that we have as a luxury that Reading Children started doing a few years ago, I want to say probably in the past 2 to 3 years ago, is we have a difficult airway response team now. So if a patient is thought to be a difficult airway from prior experience, like maybe it's a Treacher Collins patient, you can call a DART, and a ENT, surgeon, PICU will all show up to the bedside within probably within like 5 minutes. So that's also been helpful as well because Bronx, we have a whole lot of different technology at the bedside. But for overall most intubations I haven't seen, we haven't had to use the burp technique. But
Excellent.
it is in our pocket.
Excellent. I am not seeing any questions and nothing other than kudos, comments in the chat. Okay, Dr. Farah.
There, yeah, so I see Dr. Farron asked thoughts on perilaryngeal airway adjuncts for peds in the field. I would love this. I would love to get pediatric supraglottics. I know we have to like move things through slowly and try to do things like pilot and whatnot. But the power of the fact that the PD part has enrolled over 900 patients so far, and that hasn't shown a clear definitive winner between BVM and supraglottics, to me goes, that's actually shows possible safety. I'm hoping at some point they'll publish it. I'm like putting pressure on Henry Wing. But I'd like to have that as an option. I
Any
know
other?
that the
Go ahead.
initial literature for pre-hospital I'm going to say supraglottic airways just because it's easier for me to sprawl off my tongue. The initial literature on it was really as a rescue device, and so it was unclear whether the worst outcomes in supraglottics were because they had already had a failed intubation attempt, and so you had a like more bloody swollen airway leading to worse outcomes, and you'd already been exposed to hypoxia and different things. So I don't think there's been a lot of really fair pre-hospital pediatric supraglottic literature that has come out quite yet. It's been used very, very safely in the hospital for a prolonged amount of time, and I think that, like as I said, with this PD part, is showing me there's a lot of safety, and the different lenses who've used it in California haven't had any issues so far.
Thank you for that. And we're definitely watching that literature very closely. One concern I would have is it could turn
Mm.
into something like pediatric intubation, where we authorize it and then take it away. And that's really hard as well. A new question for you. You talked quite a bit about using high flow oxygen in various different forms in the pre-hospital setting. And I wonder if you have any comments on both the logistics of being able to do something like that, and also, as we saw during the COVID pandemic, the pure volume of oxygen a rig would need, say, for an interfacility transport or even a long 911 transport. Just the practical sort of side of doing something like that, even if it does turn out to be safe and efficacious.
I would say that I would, well, at the Children's Hospital, because we have, and at your ERs, if you have the technology, we start with the heated high flow nasal cannula. But I would say you start with the equipment that you have already on the rig. So we already do BiPAP in adults. So this would just be getting the modified masks for the pediatric patients, for the sizes, to be able to allow them for the younger ages. So I would say in lieu of initiating heated high flow for EMS, I would say if you have a patient who's in a lot of respiratory distress, that is not looking great. Currently, all we have right now is you can augment their breathing with BVM, which is definitely a tool that you have in your pocket. Let's say like you have a submersion injury, the patient's really retracting, you can help them with a BVM with breathing with them. But if you could try a pediatric CPAP, just like you would for an adult with respiratory distress and failure, I think that would be like a more powerful move. Use the equipment we have and just change the face masks that you have to carry. Oh, I'm saying all this and I haven't looked at it with my own agency quite yet. I've just been hearing it more and more and been talking to Dr. Kaddish about it. So I'm sure I'm giving some people at San Diego Fire some palpitations with this lecture.
Thank you for that. There's a couple of questions in the chat.
Yeah. So Scott Kunkeler asked, is Radies working on putting together the treatment pathways and algorithms to send out to the local ERs to use? We actually had been working on this for a number of years. I want to say, probably 4 to 5 years. We actually had an output team, and we had shared our, I think it was bronchiolitis, asthma, DKA pathways. And they were working on some more. I think it's a huge load of work on teams who are using their voluntary time. And I think if we were to get feedback that this is really wanted and it was really useful when we did it, I think we'd be really happy for the people who are putting in the work. We are trying to get them to do it again and submit it through our new EMS for Children Advisory Committee, so it could be shared to us and we could be able to disseminate it out. I know that the last time we put them out, the person who does QA for our hospital wanted to know who was actually using the algorithms. And so it was in order to get the treatment pathways, you just had to go, I think there was like a quick survey you had to fill out. And so we are still continuing to work on that. And if you're interested, we can give more information at our next EMSC update. And Oliver, can you take that as a note? And then for Brad Schwartz asked, how important is the sniff positioning for supraglottics in kids? I think airway position is always key, no matter where, no matter if you have a supraglottic airway in, or you have bagging, or you just have them sitting, whether they're in a car seat or laying flat, like having them in a good, there's anything respiratory, if they're altered, you always want to make sure that they're in a sniffing position. So yes, 100%.
Position.
I think that
the key is key.
I think the thing that I would say is more problematic, Dr. Schwartz, is you just want to make sure that they're in the supraglottic is in the correct spot and that it's secured in a good position so that when you have the movement, you don't have any dislodgement. Now, again, I think because we have continuous end tidal CO2s that you can see when things shift and move, and the movement of the supraglottic airway isn't quite as dangerous, I think, as the endotracheal tube movement. That's a great question.
Excellent.
You guys are a very dynamic group. Thank you.
Any other questions or comments? I don't see anything in the chat. I don't see any hands raised. If I'm missing somebody, please come off.
I have a question for the audience.
Oh, that's not allowed. Just kidding. Go ahead.
I tend to reuse my lectures a lot, and I know that we have a large variety of audience members. Would you mind sending me feedback on if you guys liked the level of anatomy and physiology I had in the lecture? So thank you guys.
Anything else? Any other comments or questions? Lots of kudos. Well, thank you very much for a really important and well-delivered talk with evidence behind it. We really, really appreciate it. And we'll go ahead and adjourn the meeting and see everyone back at 1 p.m. Thank you so much.